1.
The broadcast is now starting. All attendees are in listen-only mode.
Well, hello, everyone. This is Güliz Barkan, the President-elect of the American Society of Cytopathology. Welcome to our webinar Wednesday. Today, our guest speaker is the President of the ASC, and I'm just delighted to be introducing him. This is going to be an excellent session, not because he's just the President of the ASC, but also he's going to be talking about this new international system for reporting serous fluid cytopathology, which we're all anxiously awaiting what it's going to be like, when it's going to be published, and so forth. But let me give you a quick introduction to Dr. Kurtycz, and really to this audience. I'm sure he doesn't even need to be introduced, but he's our president. He is a professor of pathology at the University of Wisconsin School of Medicine and Public Health. And he earned his medical degree from University of Michigan, go Blue. And his residency was at University of Wisconsin Hospital and Clinics and the University of Kansas Medical Center. Now, on a fun note, Dr. Kurtycz is a wonderful ballroom dancer, and he gets to dance with his wonderful wife, Dr. Tina Kurtycz, who is a pediatrician. And he's also an artist. He does pottery, and he's a wonderful cytopathologist who was involved with the multiple systems for standardized reporting in cytopathology. So without further ado, I give you Dr. Kurtycz.
Right. Thank you, Güliz. But before I begin, I really want to thank you and the members of the American Society of Cytopathology, EB, and the ASC office staff for putting on this educational series in response to the pandemic. COVID disrupted our semesters. It interfered with our schools and hospitals such that all our trainees in cytology, students, residents, and fellows, had the course of their studies hurt significantly. And the ASC has tried to help in some way by putting on the series, and Dr. Barkan led the charge. And I also want to thank Joanne Jenkins for supporting us with this activity every month, and we have a little ways to go. So at this point, I'd like to begin. The International System for Reporting Serous Fluid Cytopathology. I have to have the obligatory shot of my institution, and this is the School of Medicine and Public Health, although most of the time I live elsewhere on campus. I am one of the editors of the International System for Reporting Serous Fluid Cytopathology, but there are no financial or other conflicts. So what are we trying to do here today? We're announcing the system. The system has been given over to the publishers. We're awaiting the galley proofs before publication, but we want to describe where we are at this point. We would like people who are listening to understand the rationale behind the International System for Reporting Serous Fluid Cytopathology, the diagnostic scheme, and the quest for standardization. Describe a systematic approach to serous fluid interpretation. And we'd like for you to be able to apply this system for reporting serous fluid cytology, its diagnostic scheme, to serous fluid samples. So some history. The antecedent of all of this was the Bethesda system for reporting cervical cytology. That system was created in response to the U.S. federal government's need for corrective action in the face of poor performance by a number of laboratories. The National Institutes of Health with Diane Solomon and Johns Hopkins with Robert Kerman kind of managed this new system. It was a consistent, simpler diagnostic terminology set, and it was based upon the knowledge of how HPV was important in the evolution of cervical cancer. the world became familiar with the Bethesda system. It's spread everywhere in one form or another, and people have gotten progressively better at it. We have had 2 inter-observer reproducibility studies that have shown how well people have taken up the system, and so it's very, very well accepted. After that, there was Bethesda Thyroid, and like Bethesda GYN, it began at the NIH and attempted to regularize thyroid fine needle aspiration. One of the major contributions of the thyroid Bethesda was to provide a literature-based risk of malignancy for any of the cytologic diagnoses, and another area to develop consistency in the terminology and handle things the same way from place to place. Paris was after that. Before Paris, even though we'd had decades of experience with urinary cytopathology, there was no uniform reporting system, and there were problems. The diagnostic accuracy for low-grade urothelial carcinoma in cytology is low. And cytology can't really rely on histologic-based WHO ISUP classes, and especially because there are problems, theoretical problems, with how the WHO and ISUP handles low-grade urothelial lesions. Are papillary lesions that don't invade or metastasize really cancer? I mean, back to, way before Virchow, malignancy is characterized by local invasion and distant spread. So in urothelial carcinoma, lesions that didn't invade and didn't metastasize were called cancer. This was a real problem for clinicians and patients, and for conceptualization of what's going on. On the other hand, the diagnostic accuracy for cytology for high-grade urothelial carcinoma is very good, and clinicians and patients were frustrated by what we did. So in response, Paris focuses on what urinary cytology does well, which is essentially the diagnosis of high-grade urothelial carcinoma. Milan arose because of confused reporting in a difficult area, that there were many different ways that salivary gland cytopathology was handled. Some people had categories, some people had descriptive reports without categories, some used surgical pathology terminology, and there was no general correlation with risk of malignancy or statement of management. And we did a survey that showed very little use of genetic studies on salivary gland cell block material. So a consensus evolved that there was need for a better set of categories and a need for clearer communication. So Milan answered that call and led to a better exchange of data across institutions and to clinicians. There were a couple of other systems that I'll just mention in passing. The IAC sponsored the Yokohama system for breast, and although in many areas where there are more developed healthcare systems, the fine needle aspiration of breast is given over to a lot of core needle. In many areas of the planet, fine needle aspiration is all that there is really available given the level of technology, and it can do quite well. Dr. Andrew Field has led many embassies across the world teaching people how to do fine needle aspiration of breast, and has been quite successful. So the Yokohama system deals with that. And the Papanicolaou Society created a reporting system for pancreaticobiliary cytology, and that work is about to enter into its second edition. So that's background. So now to the Serous fluid cytopathology system. The beginnings of the international system, as it's called, was begun in the European Congress of Cytology in 2018. And originally it was going to be called the Madrid system, but then some individuals wanted to also, because it was one of the leaders was from Portugal, it might have been the Porto Madrid system, and then people began discussion, and so finally we evolved to the international system. The IAC began this effort and invited the American Society of Cytopathology in. That the lead author is Dr. Ashish Chandra, that you can see over on the left, Barb Crothers. I had some role, and then Fernando Schmidt. So why even do this system? That people were looking for consistency in diagnosis and terminology for what is a very frequent sample in a cytopathology laboratory. And we wanted some consistency in communication to clinicians and consistency of management, consistency in the most relevant ancillary studies for patient samples, and to define what's a true negative for us, putting some bounds on atypia because it's overused, and what is needed to make the diagnosis of mesothelioma on a cytologic sample, and what are the implications of benign epithelial cells in some of our fluids. We also wanted to establish a framework that would allow comparison of results in studies to continually improve our diagnostic capabilities. So, as with all of these studies, we start off with a survey, and we reached around the world through the good offices of the International Academy of Cytology and the American Society of Cytopathology to ask people how did they practice fluid cytopathology. So we got a good response. We got 593 participants responding to 54 questions. Admittedly, that was a lot, and I appreciate those of you that didn't contribute. So we had people from all sorts of practices and all sorts of institutions, and we achieved our goal of getting a truly international survey. You can see that we were, in the US, contributed slightly less than a quarter of the answers, and that's usually not the case. We usually overwhelm. But here, 26% were from Europe. We had significant input from South America and Asia. And so this does reflect practices across the planet. The years in practice for these individuals varied between 0 and 60 years, with a mean of 16.4, and the volume between 4 and 10,000 samples annually, with a mean just close to 1,900. Large standard deviation there. So some results from our survey. 90% of the participants added general category, negative, atypical, suspicious, or positive to their reports, but 78% generate reports with only a general category rather than a surgical pathology type diagnosis. 32% report adequacy on all samples, and 33% only on some samples, and 36% don't report adequacy at all. And those that report adequacy on some samples do it when the samples are too degenerate or poorly stained, or there's another reason that they can't make a decent interpretation. 76% of the participants here don't require a specific number of cells for adequacy, and nearly 60% don't even believe it's reasonable to try to call adequacy on a specific number of cells. 61% would make a diagnosis of mesothelioma if the cytology, the cytomorphology, and the immunochemistry were supportive, and a overwhelming number wanted to see a section purely on mesothelioma in the book, in the monograph. Of interest to me was that nearly 3/4 believe that everyone should be doing both Papa-Nicolau stain and modified Giemsa stain, like a DIF-Quick standard for all of these fluids. Let's see, about 78% prefer suspicious for malignancy over other terms when we have an intermediate type of morphologic pattern that we're not quite sure of. 58% use both suggestive of or suggestive for or suspicious for malignancy and or consistent. So there's a lot of variable terminology for the sort of if kind of lesions. 65% use definitive terminology when they can, but 86% use consistent with additional information or studies are not available. And 63% wanted to keep having a typical term, and 96% agree that malignant cells should be qualified as specifically as possible with ancillary studies. So this is our background for the system. And then we had some questions on ancillary studies. And a lot of people, 70% regularly perform ancillary studies on serous fluid. Use of different sorts of preparations. Most use cell blocks. Some use cytospins. A few use direct smears, and a minor number, 12%, use thin prep type of liquid-based preparations. 73% regularly perform ancillary testing on atypical and suspicious samples, and a certain number indicates that they can perform genetic studies on serous fluid samples. Some can do FISH, and some can even do next generation sequencing, and a fair number do their testing in-house. Of interest, though, 78% would accept a two-stage type of reporting system for indeterminate diagnoses while awaiting confirmatory studies, meaning that initially you could call Atypia, but use that as a preliminary diagnosis. And then when your ancillary studies are done, you put out a final diagnosis. And more than half, 64%, indicate that they currently do some sort of two-stage reporting system in their institution. So, given all of that, the diagnostic categories were formed. We have formed. We have a non-diagnostic, negative for malignancy, atypia of undetermined significance, suspicious for malignancy, a malignant primary mesothelioma, and a malignant metastatic or secondary, and to indicate cell type and origin if possible. Given that the proposed diagnostic categories are similar to some of the other systems, still there's a need to determine criteria and risk of malignancy for each of those categories to know, to more precisely put our samples into these categories. And following in the footsteps of the Bethesda systems, we started putting the book together. CSF, synovial fluids, aqueous, vitreous humor are not included, as those samples tend to be too site specific and have their own special characteristics, although you can probably carry the same sort of criteria into CSF, but it's specifically these sorts of other samples were not included. Of interest, one of the things that we really had to have was a baseline risk of malignancy, and the cavalry coming in to save you, or knights riding in on the chargers, Dr. Farahani and Baloch did a study, a meta-analysis of nearly 35,000 samples, and looked at what the risk of malignancy, given our diagnostic terminology. And they found that 17% of non-diagnostic samples were associated with malignancy, 21% of those that were deemed negative, higher number, 66 for AUS, 82% for suspicious, and 99% with a small standard deviation for things that were overtly called malignant. This study actually is a baseline. As we define the categories, as we carry forward with education for the TIS, we're hoping that these sorts of risks will improve, but it remains to be seen. The monograph structure was laid down with our co-editors and chapter leads, and we came up with 12 chapters, which will be seen in the forthcoming monograph. We'll discuss each of them in turn. Non-diagnostic, for consideration, what makes a non-diagnostic sample? Is the sample non-representative of what we're going after. Like, is it only blood? Is it a bloody tap? Is volume important? Is cellular content important? Is cellular preservation important? The decisions. We know the clinicians give you what they can get, and the volumes and cellular components vary, and there's no really good data on the valid number of mesothelial cells in the literature. Any abnormal cell makes the sample diagnostic. And only really if the sample is totally blood or totally degenerate do we consider non-diagnostic. Again, they give you what they have. We report what is given in the sample. For instance, this sample, which most of us will recognize as a hemolyzed liquid base prep with a rim of degenerate material around the edge, we would consider that non-diagnostic. In most of our diagnostic systems, authors have chosen a reasonable but arbitrary starting point, and then they ask the literature to validate or invalidate that point. So thyroid right now, we have, 6 group of 10 cells. Salivary gland, similar. Urine, we have some measures of volume, but, again, those are arbitrary. A probabilistic approach to all samples that are suboptimal is maybe what we need to take. A well-mixed sample of 75 milliliters or greater is likely to have the correct information unless it's a bloody tap. There are some papers out there, principally one by Roper and Dr. Ali and Dr. Olson from Hopkins, and they indicate that about 75 milliliters tends to give you a good fluid sample, 60 milliliters for pericardial. But, smaller samples may have the correct information, but will probably be less likely contain the answer than the sample with greater volume and the greater chance for a false negative. If you look at this hypothetical graph to the right, the greater volume is more likely, the greater the volume, the more likely one is to have a representative sample of the disease process, and the more likely you're going to be able to make the right call. When the volumes are low, you still may get the right answer, but you have a slightly decreased chance of seeing the etiology of the effusion. When I handle low volumes, I put in a statement, due to the small sample size, the identifying feature of the disease process may not have been present in the sample if it isn't overtly positive. I never tell my clinicians that the sample is non-diagnostic or insufficient. It just causes them distress, stimulates unnecessary phone calls, and since the patients can look at the charts, it leads to a lot of questions to the clinician that they are going to have a difficult time in answering. For small samples, I do indicate that the sample size is small and that the material is scant, and it helps keep the peace. Always tell them the truth. We do know that for every additional sample and additional amount of sample, finding comes closer to reflecting what's really going on. After Mark Stoller, in the last project, the number of samples, the amount of sample that you get, as it's increasing, it reflects the true biology of what's going on in the patient. The more you get, the more you know. But past a certain point, the incremental knowledge you get is not much. For us in serous fluid, according to the Roper, Ali, and Olson, it may be around 75 milliliters. Another example for that is fine-needle aspirations. We once did a study on transtracheal and transbronchial, and after 4 passes, the amount of additional information that you got from additional manipulations was usually fairly low. So, examples of non-diagnostic. In A, we have material from an abscess, empyema, pleural cavity, or abscess elsewhere. It is diagnostic. It gives you information about the condition and the disease process, and the sample is suitable for culture, and report that out. But in B, that's a hemolyzed fluid, and that isn't giving information, that there's been some technical problem or a bloody tap, and you've got what you got. And the bottom two samples, B and C, the cells are too degenerate to read, and so they also would be considered non-diagnostic. Next category, negative for malignancy, samples where there are clearly no neoplastic elements, only the expected cell elements in variable numbers, and usually it's mesothelial cells, macrophages, and other admixtures of inflammatory cells. This chapter has a lot of examples of normality, and talks about why cells are the way they are, how cells are impinging on other cells, and reactive and just plainly negative fluid. There is some concentration on the finding of windows or spaces between mesothelial cells, and those are due to the presence of microvilli, which actually push cells apart, but on light microscopy, you can't see these microvilli, so they do look like windows. Cells are connected to cells through desmosomes that are on the microvilli and help form those mesothelial sheets. In negative for malignancy, there may be conditions, inflammatory, immunologic, infectious. These are not deemed atypical. For us, atypia should be reserved for concerns about malignancy, not for things that we can readily explain that are on a non-neoplastic basis. Of note, Dr. Wojcik from Loyola put together this flow chart, which is one of the central features of the new TIS system, and talks about how to handle effusions regarding adequacy, regarding normal cellular elements or abnormal cellular elements, and where special studies, here demarked by the red stars, are necessary to help you define what's going on. For example, if you have an adequate sample with unexpected cellular elements and you have single isolated cells, you can consider melanoma, lymphoma, or non-cohesive carcinomas or sarcoma, and then you may need some ancillary study like a HMP45, melanoma cocktail, or other to help define the entity as melanoma, similar for other adenocarcinomas and whatnot. But some things which are abnormal findings that are plainly not neoplastic are considered negative for malignancy, psammoma bodies, collagen balls, LE cells, etc. So, necrosis here, things like rheumatoid arthritis, you can get debris, and so it doesn't automatically mean that the etiology of a necrotic material is neoplastic. So atypia of undetermined significance, AUS. Some people don't use atypia at all, and it may be at times due to the quality of the cellular elements that you may need to use the term, but we try to refrain as much as possible. Atypia may be used as part of that two-step process that I mentioned, where you see some odd cells, but you put atypia out as a preliminary diagnosis until your cytochemical, immunologic, or genetic analyses are over, and then if you can classify it definitively, you do so as a final report. Sometimes, though, a sample can't be resolved, and atypia must be used as a final diagnosis, but again, I'd like to avoid that if possible. So here are samples that, atypia may come up. In the middle of a bunch of proliferating mesos, you have an odd group, and you don't know, is this from a cancer or not? Certainly, there's not an overwhelming number of these cells in this background, and it certainly makes you worry. To go to the Giemsa type stain, the Romanowski stain, with a similar sort of feature. Actually, in this case, there was a small number of malignant cells, so this was taken to adenocarcinoma, and the matter was resolved, but originally was atypical. dealing with atypia, it's difficult to find any medical test that can always separate a disease population from a normal population. There's always some overlap in the values, and it doesn't matter if it's chemistry, hematology, or even morphology. There are patterns, as you well know, in morphology that don't allow you to resolve tumor versus non-tumors. And this overlap is the atypia. The performance of your test also will depend upon where along this axis a person makes their cut point, their decision point. It is a lot more subjective with regards to morphology than it is the numbers generated out of a chemistry analyzer or a hematology analyzer. And we all know of people who are more sensitive or less sensitive when making a diagnosis, and they vary where they make this cut point on the x-axis, where their abnormality triggers them to make a diagnosis. But if you move it to the right, you have a less tendency for false positives, and the higher the diagnostic specificity, but lower sensitivity, you can miss some things. If you move to the left, the higher the false positives, lowered specificity, but higher sensitivity. You won't miss anything, but your diagnosis won't be quite as good. So TIS prefers a shift to the right for most of us and decrease the numbers of atypical diagnoses. The domain where atypia resides, somewhere between benign reactive and suspicious for malignancy, and AUS should have a higher risk of malignancy than benign changes, but less than suspicious. Degeneration or preparation artifacts impair morphology, and experience or good quality control can help. There are other sections in the monograph that describe good laboratory practices and correlation with histology, which will help you fine-tune your cytology, leading to more secure diagnosis and the avoidance of indeterminate categories. Suspicious for malignancy, there are very few studies that concentrate on suspicious for malignancy. The Farahani and Baloch study found a rate of 2.3% in those nearly 35,000 cases. Here, the pattern is more worrisome, but you can't bring yourself to make the definitive call. It's either quantitatively or qualitatively deficient, a bit more than AUS, but not enough to let you really give a secure interpretation. And things that you call suspicious for malignancy may be part of that two-stage process. You may call it suspicious for malignancy while awaiting ancillary tests, but problem using that is using suspicious for malignancy very often it gets interpreted as positive by clinicians, or that you can have a lot of frustration on the behalf of clinicians if the answer is unclear. So, is this adenocarcinoma? Looks bad. Is this lobular carcinoma? A lot of small cells, high NC ratios, irregular nuclear forms, but if you don't have much of this on the slide, you're probably not going to make the overt call until you can get some help. The malignant categories, there are two malignant chapters in the monograph. One malignant P, or malignant primary, for mesotheliomas, malignant M for secondary or metastatic malignant disease, and usually the metastatic disease is easier because you may have history and you'll have two populations in a body fluid, right? For malignant P in the past, there was a question, could we make the diagnosis of mesothelioma on morphology alone? But in the modern era, that isn't all we have to rely on. With good clinical and radiologic correlation with appropriate ancillary test, we can do it. If there is mesothelial proliferation with inconclusive testing and a little clinical suspicion of mesothelioma, OS may be an appropriate response. But if you've got if you got the evidence, good clinical suspicion, ancillary test, then you can make the call. It's warranted. Definitive primary malignancy can be determined if the sample is cellular, with spheres or berry-like morals or individual cells, mesothelial morphology and immunochemistry markers, WT1, calretinins, CK56, D240, but knowing that all these markers have some overlap with other entities. Malignant features or overt nuclear abnormalities, including karyomegaly and isonucleosis, etc., and loss of BAP1 by immunochemistry or deletion of P16 by FISH or loss by IC, and positive clinical and radiologic correlation. So here is an example with just loads of these little berries and highly abnormal supracellular sample. Here, higher power in a different sample, you have lots of irregular nuclei, higher NC ratios than warranted. You may be able to see some windows between cells, but of course that's not enough. And so this malignant looking group, if you have appropriate staining, will help you make the call. Problem is that mesothelial cells sometimes are the enemy, and in reactive conditions, as here, they can look quite bad, they can look quite excited, but this was taken from an inflammatory fluid and did not stain positively for BAP1, and so we have to be careful, as our forebears always were. This is an example of BAP -1 loss in mesothelial cells, that these mesos don't have it. Cells in the background, mesos, inflammatory cells, are loaded, and so there are controls versus this. Metastatic disease, very often it's easy, and you have terrible cells here, a trivial diagnosis. If you have pigment, you might be able to easier call this melanoma, but it certainly is high in the differential with isolated cells with huge pleomorphic nuclei. And unfortunately, very often, there's metastatic disease from serous carcinomas, other things from ovarian origin that readily apparent, and you usually will have history to lead you to the right direction. One of our other chapters is Ancillary Techniques. Dr. Lucas Bubendorf headed this, and there'll be descriptions of clinically useful immunochemical and molecular markers based on recent literature. Both diagnostic markers and predictive markers are discussed. For instance, this is images of PD-L1 checkpoint inhibitor on different cytologic samples. The A sample is a cell block section, and it shows membranous PD-L1 staining in the tumor cells and weakly staining in the macrophages in the background. B, C, and D are direct smears and show different staining. B is positive, C is negative, but still you have a macrophage in the background showing positivity, internal control, and then there's some variability here. Other techniques, Dr. Bubendorf shows the use of FISH analysis, a Eurovision type of probe on a mesothelioma, and so that you have multiple copies of 3, 7, and 17 chromosomes through chromosome counting probes, and a loss of 9p21, which is where P16 lies, loss of a suppressor gene that can help the diagnosis. There are informations there's discussion throughout the book on clinical management, And the distillation of that is diagnoses can be made on direct smears, cytospin, liquid preps, cell blocks, and clot sessions. If you have a non-diagnostic sample, it should be repeated. If it's negative for malignancy, if there's clinical suspicion of something still going on, the sample or the study can be repeated. But if you can give a specific diagnosis based on what you have, as in our previous empyema or features of autoimmune disorders or infectious etiology, you make the call. If you have atypia of undetermined significance, ancillary testing is called for to exclude malignancy, possibly repeat studies, suspicious for malignancy, similar. And malignant, you make the call. If primary mesothelioma correlate with clinical findings, biopsy, radiology, whatever you have, and the secondary, similar, ascertaining the primary and prognostic predictive markers. So, I have some questions for you at this point. Not a poll as some of the others. We'll just give you 10 seconds. So, a 58-year-old man with no prior history is presented with shortness of breath. Chest X-ray shows a lung mass, and the pleural effusion is most likely positive for what? Okay, the answer should be the history as a lung mass, and so TTF1 and napsin A, that pleural effusions are often how lung adenocarcinomas present, and lung adenocarcinomas usually often confirmed by TTF1 and napsin A. Advanced lung carcinomas are subjects for targeted therapy. The other choices there, WT1 and calretinin, highlight mesothelial cells, PAX8, CD10, renal cell, SOX8, HMB45, melanoma, and NKX 3.1 and PSA markers for prostate. Next question. 78-year-old male presented with pleural effusion. What molecular test, given this picture, will be requested by the oncologist? So there's pigment here. This is pretty obvious, but so a second order question, BRAF is what the answer should be. Melanoma may be a diagnostic challenge because, especially if there isn't pigment. But you do have an isolated cell population. They are discohesive. Cell clusters are very uncommon. Nuclei are large, and nucleoli tend to be very, very prominent, but there's a whole spectrum of change that we are familiar with in mesothelioma. Cytoplasm is usually moderate to abundant, and if you're lucky, it'll have pigment. 40 to 60% of malignant melanomas harbor an actionable BRAF V600E mutation, and therapy can be based on that. HER2-neu, breast carcinoma, ALK and EGFR, lung adenocarcinoma, c-KIT tested on GIST or gastrointestinal stromal tumors. An abdominal fluid 72-year-old male is shown here. Possible primary site is so relatively small cells, although you can see some lymphocytes here, and they're a few times larger than the lymphocytes and nuclei are. But you have some cytoplasmic vacuoles, signet ring formation, so the answer is stomach. The best answer is stomach. A significant form of gastric carcinoma is characterized by the signet ring, where you have large vacuoles that push the nuclei to the side, and large intracytoplasmic vacuole. Lobular breast carcinoma, though, can also present a signet ring, and adenocarcinomas, lung and pancreas can do it too. So it isn't absolute that it has to be gastric, but it's just the most likely. Final question. 78-year-old man presented with pleural effusion. Given this thing, the most likely diagnosis is lung adeno, metastatic squamous cell, reactive mesos, mesothelioma, metastatic pancreatic adeno. The correct answer is mesothelioma, and I recognize that the picture is totally unfair without additional information, but you can see epitheliated mixed type mesothelioma exfoliated in serous cavity fluids. The sarcomatoid type, less so, but the epitheliated mix, more so. Smears are comprised of single cells and clusters, and usually have a fair amount of cytoplasm with a pale rim, and certain cytogenetic losses are often present, and loss of BAP1 by immunochemistry. Now, it would have been much more fair if I gave you that, but that also would have given it away without even need for the cytology. These are our chapters once again. And to finish off, there's a special chapter by Dr. Chris Vandenbush and his compatriots that talk about special consideration relative to peritoneal samples, consideration for benign non-mesothelial epithelial cells, ciliated epithelial cells, talks about endometriosis, and other things that you may find that can be confusing. Also consideration for borderline tumors as well as malignant etiologies. Donna Russell from the University of Rochester and Dr. Dipali Jain add their cytopreparatory expertise on a chapter that's devoted to cytopreparation, talks about features that we need to be aware of for direct smears, liquid-based preps, molecular preps, and a lot of cell block techniques are described with appropriate references for your own laboratories. There's a quality management chapter that goes from top to bottom and considers all the activities that are contributing to appropriate analysis of serous fluid, from pre-analytic submissions to the reporting results to clinical colleagues. Descriptions of policies and procedures and proficiency testing are given. And final chapter is an excellent chapter by Dr. Stefan Pambuchian on the anatomy, embryology, physiology, and general pathology of those fluids. That it's a real tour de force, and for me, it was a very, very good read. It talks about everything from how Starling's forces can help generate transidates and exudates to mechanisms of malignant cell occurrence and invasion of the body cavities and their occurrence in various sites. So the final thoughts: this system, like all the other diagnostic systems, to be used and then challenged. We've had lots of papers written about the other systems, and this should be no different. All the diagnostic systems purport to be living systems capable of evolution. If we can make them better, we need to. And every few years, there will be new editions of these systems as new information comes to the fore. But we need to have the consistency of these systems, that they need to carry similar messages across to our clinical colleagues. Cytology has to be useful to them. Otherwise, they will result to histology and other forms. The cytologic diagnosis, the cytologic system of diagnosis, the method of diagnosis has to be supported by uniformity and new findings as they come along. The authors and editors invite your comments and thoughts for improvement. So thank you very much for your attention. And this concludes my talk.
Well, thank you very much for unveiling the international system for reporting serous fluid cytology. There are a bunch of questions that I have and our participants have been writing, so maybe we can get to those. So first of all, one of the questions is, what do you do in terms of morphologically to differentiate reactive mesothelial cells versus mesothelioma? In other words, what prompts you to get the BAP immunohistochemical stain and send it out for fish? What are the things you want to see for mesothelioma?
Well, the easiest one, if you have a very, very cellular sample and you can't see two populations of cells, if you can't readily discern them, you can almost make the call without, if there's good clinical evidence. But nowadays, I think that we're tending to rely on that more and more. It gets progressively harder as you don't have an overwhelming number of cells, and you may miss it. That's been classically the problem. But if you have suspicion, then you should order the stain, and it will help give you security. The P16, the BAP1 or MTAP or others that will help your security. But it's still probabilistic, right? I hope that's a good enough answer for you.
That's true. I mean, like for our trainees, for residents and the cytotechnology students, the book teaching was that you have to see these large giant cell balls, which are 100 cells and more, or you see the cell and cell or the cannibalism, that sort of thing. Those are the things that probably make you worried that there's a possibility of mesothelioma, correct?
Yeah, but those are pretty overt. Now, I think we're getting a bit subtler, but still, it has to be, in the appropriate context.
Correct. Okay. So in the ideal clinical scenario, you have all the text X-ray or the CTs, and your lab has BAT1 or the P16 fish, but life is not ideal as always we want it to be. So perhaps in a situation where you don't get the clinical history and you don't have these fun toys in your fingertips, can you ever call a mesothelioma, or should you hold back from calling a mesothelioma if you don't have the clinical history and the ancillary studies to back you up?
It will be proportional to the amount of information that you have. If it's overt sample like the one I showed with all of those cells everywhere, you possibly can, but you're never probably going to engage in much effusion cytology without an X-ray being available. Yes.
Okay. So that's a good message to our participants. Okay. Another question from one of our participants is, how do you differentiate between a hemorrhagic tap and an hemorrhagic effusion in malignancy, for example, they ask?
If you have only blood or only hemolyzed material in there, then you can't. You'd have to see some cellular elements to begin to think it's a malignancy-derived bloody effusion. But it goes to what I usually tell the clinician exactly what I see. And, if you don't have any cells, you can't make the call. If the radiology shows that there may be some peel or mesothelioma type growth, then you may have to go for a sample, histologic sample or core sample. If the cytology isn't giving it to you, you may have a sarcomatoid type of mesothelioma that doesn't readily put off a sheet of cells into the sample. And so, again, we won't be perfect. We can't make the call in every type of situation, but we do as best we can.
So along the lines of that, the adequacy, so this international system now actually gives you a somewhat of a magic number, the cutoff point of 75 milliliters, as you said, from the Matthew Olson study from Hopkins.
Yeah.
What do you do? Say it's less than 75 milliliters and you don't see any cells. Is that a time to call it unsat?
Again, I would, it'd be odd that you wouldn't see any cells. You might see mesos, you might see other cellular constituents. It would be, really odd for a sample to be totally acellular. And so I report what's there. And again, as I mentioned in the talk, that it's a probabilistic approach. Small samples, maybe diagnostic. There is nothing magic about 75. It was just shown that it better correlates, the more sample better correlates with true disease, but you may get the answer out of smaller samples. I tell them what's there, and I do indicate that the sample size was small. And I guess what we can say is that given what exists in the literature right now, sample size under 75 may be considered small. But realizing that that's still probabilistic.
So there's a possibility of calling it unset if you don't have any cells. Then that was
but how it would be very odd that you get such a situation that you'd have no cells unless somehow you tapped into a catheter. You may not have the malignant cells, it may not have the diagnostic cells, but you still should have something.
Okay. All right. So really the bottom line is if you don't see any mesothelial cells, if you're just seeing, say, red blood cells, that might be the time.
Yeah. If you only see cells, then it's likely to be a bloody tap. But,
okay.
It's very, very, again, report what you see. And I would, if I only saw red cells, call it inadequate.
And so with this new system, the adequacy criteria or the, calling the adequacy is true for pleural and peritoneal and pericardial effusions, or are they different from effusions to, say, ascites or washes?
Essentially for us, they're similar now. In the peritoneal chapter, yes, there is some description of what goes on in washes separate. So, you'll have slightly different sort of patterns in a wash. You've introduced usually saline in there, and so they're and the cells might be fresher. It kind of may be analogous to what goes on with a bladder wash versus a voided urine. That's a very loose analogy, but you can see some very good morphology in peritoneal washes. And so that is discussed in there. Okay.
So you're referring us to the book too. That's good. Another question is comes out of the cytopreparatory or maybe even the a priori. What is the best way for the samples to be sent to the laboratory? Fresh or fixed, to refrigerate, and so forth. Actually, this falls in the realm of Donna Russell's chapter. So what should people be doing?
Well, fresh is always best if you can get to the laboratory in within a couple of hours. It shouldn't sit on the unit clerk's desk for a while until it can start to deteriorate. There are problems with adding fixatives and even refrigeration. It's left in the fridge too long. It can start growing things. If you just dump in an equal volume of alcohol, like we tend to do for GU samples, you can get protein precipitates that can interfere with later processing. But there are, depends upon what's in the fluid. Fixed is better than totally deteriorated, but you stand a chance of getting a precipitate. So going back to the beginning, fresh is always better. If refrigeration is next, if it's within a certain timeline, then if you don't have an alternative, you have to add some fixative.
And for fixatives, what would be the best fixative that people could use?
It depends on what you're trying to do. I'm old school with Dr. Frost always used to like to have an equal volume of 50% alcohol, but if you if it's going to sit around, that's probably still the best and the most likely thing that you'll have ad hoc. We certainly don't want formalin out on the floors except in small vials for biopsy, and that won't be anywhere close to our 75 milliliters. So I think that's still the case.
And also probably to remind the floors that they're going to add any fixative to let us know, because you're looking at the volume. So you don't want like 10 milliliters of actual specimen and 100 milliliters of fixative sort of thing.
For sure.
Yeah. Okay. A couple other questions. Do you recommend any comment saying negative for malignancy, psammoma bodies seen on the possible causes? There are case reports for gynecologic and peritoneal malignancies that have shown psammoma bodies in the peritoneal fluids, just like in cervicovaginal smears. The question is, what do you do with the psammoma bodies?
Well, this is relevant. I had a case many years ago. This is totally anecdotal, where I had psammoma bodies in a sample, and there were a couple of cells adherent to it. They looked relatively benign, but I wanted to talk to the clinician, and I did see some slight changes. And so again, years ago before this system, I did call it atypical. Clinician never called me back, and the lady later developed a serous adenocarcinoma. Or had a serous adenocarcinoma at the time. And there was a lot of discussion why the clinician never called us back. So my endpoint is psammoma bodies are worth reporting. If you see, you check for cellular elements, and if you see anything abnormal, you ramp up what you're going to call it. Psammoma bodies can occur without any malignancy as laminated concretions just in a peritoneum. It doesn't automatically make you call it atypical. You need some odd cells. And I think the literature certainly bears this out, and that was one of the points of Dr. Wojcik's flow chart there, that unless you see something odd with it, adherent strange cells, you pull back.
Okay. And this could be seen in very benign conditions too, like endosalpingiosis and whatnot. So
for sure.
And similar to that, if you see mucin without accompanying atypical or tumorous cells, essentially the pseudomyxoma peritonei or something like that, or maybe it's just the mucin and not the cells, what would be the way to report in this system? Would it be negative for malignancy, mucin present?
If you can define it as mucin, the problem is with our stains, with our stains, is it mucin or is it some protein? Maybe you can. If it's mucin, just like in the salivary gland, you start getting worried, because of things like in the appropriate patient pseudomyxoma, and so I would probably actually engage in some communication with the clinician, and I would certainly report it as present. I have a problem right now, not having had a tremendous amount of experience with it recently. And I don't remember what Chris put in that chapter, but I think it may warrant, if you really think it's mucin, either on the gross or microscopically, that I might start thinking about atypia. Because I'm really worried, of course.
Right, for the presence. Okay. Another one is, when is the book going to be available? People are asking, when is the book ready?
So we're waiting for the galleys. And so I do not have a specific date. I should have bothered the production editor more. I am anticipating within a couple of months.
So perhaps by our annual meeting time in November.
It's got to be out by then. Yeah.
Okay, good. So those of you who are going to be virtually attending our meeting, which I'm hoping you are going to be, you could be able to purchase the book there too. Couple other questions, if you don't mind me asking.
Sure.
So somebody has a two-part question, and it's about the risk of malignancy being on the higher side in the negative for malignancy category. And I'm thinking that they're alluding to Dr. Farhani and Baloch's study.
For sure.
So what were the common malignancies that led to the false negative interpretations? And two, should we have a lower threshold for trying to make a cell block based on this if we have enough material?
Well, it depends upon the site. What are the common malignancies? And everything there was similar to what's been classically taught, right? It was that in the peritoneum, in women, it was those malarian-derived lesions. In men, pancreas, colon. In the pleural cavities, lung. So nothing astonishing there, but the use of cell blocks is progressively encouraged for special studies and for histologic correlation. And as cytology, in general, is looking at small biopsies to help extend its reach and expertise, the cell blocks fall well into that. So, but as to the nature of those types of malignancies, it's from my reading, it's what had been classically taught, and what we got from Dr. Frost 30 years ago.
Okay, all right, sounds good. Another question is, how often do you see the squamous cell carcinoma of the lung metastasizing to the acidic fluid or being found in the acidic fluid? In my experience, that would be very rare. Yes. Although to me, all those years I've been practicing, maybe I've seen one or two for squamous cell carcinoma, but maybe what is your?
I would absolutely concur. Usually the bronchogenic carcinomas, that the squamous cells, even in the small cells, tend to be central, and that the adenocarcinomas, a classic thing is that you can see more of them peripherally. I have only seen, as per you, a couple of squamous cells that have gotten out, but usually, people who weren't especially well treated, extensive disease, or sometimes you can get mostly even in scar carcinomas, it's an adenocarcinoma. So we have some examples in the book, but it's a rather odd circumstance. So
there are some BAP1 questions, and I'll put all those questions together. First of all, the BAP1 loss. Do you always have a BAP1 loss in mesothelioma? Could you ever have a mesothelioma without a BAP1 loss? So that's question one. And two is, do you need both the BAP1 loss and the P16 fish on mesothelioma, or is just one of them enough for you given the right clinical circumstances?
Well, I remember listening to Dr. Chert from Canada, and he likes to have both. Or he did a BAP1 loss and a negative marker for adenocarcinoma. So he would do it on two of those, and and so I think the BAP1 loss alone is might motivate him. But is it ubiquitous for everyone? No. Offhand, I'd have to look up the number. And
and that's oh, you have it there.
it's pretty frequent, but it's not absolute. So I can probably, I'd have to look that up.
Yeah, that's all right. That's all right. And yeah, I do remember Dr. Short gave a lecture on that too. And, whenever there's an immunohistochemical stain, there's always studies kind of against it.
Well,
And-
sure. But I mean, nothing is perfect, right? No diagnosis is absolute. But it's quite reliable. And so if you have the loss, then you can be fairly confident that you have a diagnosis. But again, it all has to make sense. Everything is the triple test. That the clinical pattern, cytologic pattern, radiologic pattern, all helps you achieve the appropriate interpretation.
Mhm.
Let me see if I can pull that up for. Keep asking, and I'll see if I can get you there.
That's okay. That's fine too. Now, there's a good question here because it sometimes appears on boards, and it's good for our trainees to know. What do you think about the Desmond stain in terms of differentiating reactive versus malignant mesothelial cells? And
I have not a lot of experience because my instructor, he wasn't a big fan of the Desmond stain. I don't know how what your experience is with regards to it.
So the verdict is out there. There's no yes for sure or no for sure, because I know it sometimes is helpful. But if you ask the mesothelioma experts, they'd rather you don't use mesothelioma or Desmond stain to differentiate.
Dr. Reza Hafez, who was our primary diagnostician for decades over here, it didn't have a lot of faith in it, and so we didn't tend to use it.
Right. Okay. And then I'll do one last question and I'll let you go. So what is the maximum time for keeping the sample in the fridge before processing? So what shall we do without pickling our specimen? How long can we hold on to it?
I find that anything more than 3 or 4 days tends to induce a lot of degeneration, and much like what grows in the back of your refrigerator, things can start growing in it. So I don't. I'm not a fan of more than 3 or 4 days. Again, don't know what your experience is.
Well, my recollection from the late Dr. Barney Naylor was that he used to lecture that it shouldn't be like if it was a Friday night and it came to your lab and set in the fridge, and the first thing in Monday morning you processed it, that would be okay. But anything more than that,
that's consistent.
Yeah, and that kind of is very practical way of thinking about it too, because it's a Friday night, you're not processing over the weekend, but anything more than 2.
A weekend. Sometimes the weekend can approach 4 days over a holiday, and that's pushing it. So about the same.
Okay. Well, thank you so much. This was such a nice talk, and it's good to hear that we are going into a standardized reporting system on the effusions, and things are going to be a little bit perhaps easier to report. And thank you for volunteering for this.
One of the interesting things of the survey was that there was a fair amount of variation in reporting systems across the planet, or reporting, serous fluids across the planet, and there was a need for some improved consistency, and that's probably why the IAC proposed it in the first place.
Okay. All right. Well, thank you very much. And we'll see you all next week on the webinar Wednesday. Till then,
Okay.
stay safe.
Bye-bye.
Bye.